Hey there, future nurses. Welcome to this Next Generation NCLEX RN review session. In this episode, we'll tackle a dynamic sickle cell disease case study crafted to boost your critical thinking skills. Let's jump in.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
Here's our scenario. It's about a 32-year-old female with sickle cell anemia presenting to the emergency department with severe lower back and knee pain, scored at 9 out of 10, fatigue, and mild shortness of breath for 2 days. These are the following vital signs: with a blood pressure of 130/82, heart rate of 102, respirations 24, temperature 100.4 degrees Fahrenheit, and oxygen saturation of 93% on room air. She came in due to severe pain in the lower back and knees, fatigue, mild shortness of breath for 2 days. She is about 132 pounds, 5 feet and 6 inches tall, and she has a BMI of 21.3 with allergies to sulfa medications, and currently takes hydroxyurea 500 milligrams daily, folic acid, and 1 milligram daily. Let's look into the patient's history and physical. She has a history of sickle cell anemia, diagnosed at age 3 with multiple vaso-occlusive crisis, acute chest syndrome at age 25, cholecystectomy at age 28. She's a graphic designer, non-smoker, occasional alcohol intake, about 1 to 2 drinks per month. She lives with her partner. And for family history, her mother has sickle cell trait, father has hypertension. And for the physical exam, she's pale, fatigued, wincing during movement, and she has scleral, icterus, dry mucous membranes, clear lung sounds, no wheezing. She has tachycardia, regular rhythm, no murmurs, and abdomen is soft, non-tender, no organomegaly, no edema in the lower extremities or extremities, tender knees bilaterally. Now, let's look into the healthcare provider orders for the diagnostics. There's orders for complete blood count, comprehensive metabolic panel, chest x-ray, blood cultures, consultation for hematology, for crisis management, and to infuse IV normal saline 125 ounces per hour, morphine PCA 1 milligram per hour basal, and 1 milligram bolus, 10-minute lockout, and ceftriaxone 1 gram IV daily, and oxygen 2 liters per minute, and to encourage oral hydration and rest. We have the lab results: hemoglobin of 8, hematocrit of 23.5%, reticulocyte count of 18%, and white blood cells of 16,000, total bilirubin of 2.8 milligrams per deciliter, and for the chest x-ray, no infiltrates on day 1. So here is your task. You're going to drag from more choices to complete the sentence outlining the nurse's immediate priorities for a vaso-occlusive crisis. So it says here, To optimize care for a patient with a sickle cell disease presenting with severe pain, tachycardia, and hypoxemia, the nurse must prioritize blank, blank, and blank to mitigate vaso-occlusion, enhance tissue perfusion, and stabilize physiological parameters. Here are the word choices. One is teach diaphragmatic breathing to reduce anxiety, obtain blood cultures prior to antibiotic administration, monitor oxygen saturation every 4 hours, apply warm compresses to painful joints, administer subcutaneous heparin for thrombosis prophylaxis, administer IV morphine via PCA, encourage early ambulation to improve circulation, administer oral acetaminophen for pain relief, initiate IV normal saline at 125 mL per hour, and perform a 12-lead ECG to rule out cardiac ischemia. Now, what do you think would be the priority nursing actions? Well, the first one that we should do is to administer IV morphine via PCA, because when your patient has full-blown vaso-occlusive crisis, their pain is intense. Now, in the data we have, she's reporting 9 out of 10. It's throbbing in the lower back and knees. And this is not something you can manage with a simple Tylenol. And remember that with a sickle cell disease, this pain is due to the blocked blood vessels that's causing those very sticky, sickle-shaped red blood cells. Now, the tissue downstream is not getting enough oxygen, and that hurts. Now, we are going to give morphine via patient-controlled analgesia to let the patient take control and get relief when they need it. It's fast, it's effective, and it's far better than waiting around for scheduled doses. And the pain management is our top priority because uncontrolled pain actually worsens the sickling process by triggering more stress. Now, the next action that you should select is to initiate IV normal saline at 125 mL per hour. We cannot forget IV fluids here because dehydration makes everything worse in sickle cell disease because it thickens the blood and it increases the chance of those sickle cells getting stuck into the microcirculation. Now, this patient has signs of dehydration. She has dry mucous membranes, and we see that their blood pressure, while still within range, it hints that volume depletion. And giving IV fluids can also help thin the blood. It will improve the circulation. It will reduce that sickling. And always remember that hydration is a core part of treatment during a crisis. It also supports the body in restoring perfusion to those oxygen-starved tissues. Another action that you should select is monitor oxygen saturation every 4 hours because her oxygen saturation is sitting at 93%, which is very not really low, but kind of on the border. It's not great either. And in a patient with anemia and potential microvascular blockages, even mild hypoxemia can have a big impact on this patient. So yes, we are going to start administering oxygen at 2 liters per minute, and that's prescribed. But we cannot just walk away. We are going to keep a close eye on how the patient responds. Make sure that we are checking the oxygen saturation routinely. And sometimes if they're having trouble breathing, then we are going to make sure that it's continuously monitoring the O2 sat. Now, this is going to help us catch any worsening early, like if they're going to start having acute chest syndrome. So this is not just about watching the numbers, it's about staying one step ahead of complications. And so the rest of the options that we got are not really applicable this time. If you selected to encourage early ambulation to improve circulation, well, this might make sense in some other conditions like post-op patients, for those who are at risk for DVTs, but not for this patient with sickle cell crisis, because the patient is having too much pain to move. And if you are going to force them to walk around, actually can make things worse. Their knees are already tender and they've already been ordered to rest. So in this situation, encouraging ambulation is the wrong move. We are going to relieve pain first before even considering increased mobility. Now, if you selected administer oral acetaminophen for pain relief, well, that simple acetaminophen will not just do anything because the pain is severe and this is something that's caused by tissue ischemia. It's not a simple headache or mild back pain. And remember, in a sickle cell crisis, we're going to administer stronger pain medications like opioids to get their pain under control. So going back to acetaminophen, this is fine for mild discomfort, but for any pain, around 9 out of 10, no, it's not really gonna cut it. Let's move on to our next incorrect option. If you selected perform a 12-lead ECG to rule out cardiac ischemia, it's quite tempting to think about chest pain here. So let's rule out a heart attack, but we have to look at the big picture here. There's no evidence of chest pain or abnormal cardiac exam findings, and the patient's tachycardia is likely from pain, could be from anemia, or maybe even the fever, not heart disease. So jumping to an ECG in this context is not necessary. It doesn't address the immediate priorities of pain and their perfusion issues. Now, if you selected teach diaphragmatic breathing to reduce anxiety, we know that relaxation techniques like breathing exercises can be helpful for anxiety, but this patient is not showing signs of anxiety. Right now, the focus should be on relieving pain, correcting their dehydration, and promoting oxygenation. So psychosocial interventions are helpful, but not when the patient is in acute physiological distress. We can save this for later. Now, if you selected obtain blood cultures prior to antibiotic administration, that's a good clinical thinking. This patient has a fever and elevated white blood cell count, so infection is a concern. But this is a diagnostic step, not a treatment priority. We don't delay pain control or hydration because we're chasing a potential infection. So cultures are important, yes, but they don't take priority over correcting the crisis, such as the top three actions that we have selected. Now, if you selected apply warm compresses to painful joints, this sounds like a kind, comfort-focused intervention, but it's not enough on its own. The pain the patient is experiencing is systemic, it's ischemic, not just muscular or localized. Also, warm compresses were not ordered, and while this could be a supportive measure later, it doesn't address the critical need for systemic pain control, fluids, and oxygenation. Now, if you selected administer subcutaneous heparin for thrombosis prophylaxis, this is a big misconception. Yes, because with sickle cell disease, it involves blocked vessels, but it's due to sickled cells, not clots. And giving heparin won't fix the problem, and it is not indicated unless there's a specific reason to suspect a clot, like a DVT. So this is an important distinction. Vaso-occlusion is not the same as thrombosis. I hope that you're able to get all those correct answers, and if you want to pause this video, please do so you can reflect on those answers that you have selected. Let's get into the second test item.
Before moving ahead, here's something you need to hear if you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month, then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
A bow tie, of course. So here it said, on day 14 at 1300 or 1 p.m., it's actually a setting here that's shifted to urgent care. There's new chest pain, cough, oxygen saturation 91%, blood pressure 135/85, heart rate 108, temperature 101.2 degrees Fahrenheit. Chest x-ray shows right lower lobe infiltrate. Suspect acute chest syndrome. Transferred to hospital for IV antibiotics, possible transfusion. Now we have the information about the patient's lab value, so I want you to scan the results for the patient's lab test from day 1 to day 10 to day 14. So I want you to scan through each of these. We have the hemoglobin and hematocrit, reticulocyte count, white blood cells. So on day 1, it was 16,000 cells per cubic millimeter, and it went up to 17,500 cells per cubic millimeter. And on day 1, chest x-ray, or actually day 2, it said no infiltrates. However, on day 14, it's showing right lower lobe infiltrate. All right, so you know the drill. We are going to supplement all these boxes. We got potential complication, assessment findings, intervention. For the right boxes, we got assessment findings to supply for the left boxes. So here are the options. For potential complication, we have stroke, priapism, septic shock, pulmonary embolism, acute chest syndrome. What do you think would best fit here? The answer here is acute chest syndrome. So the patient shows classic red flags of ACS. I call that as ACS, or acute chest syndrome, because she reported that she's having new chest pain. There is a productive cough, a fever of 101.2 degrees Fahrenheit, and her saturation is 91%. Now, when you look into the chest x-ray, there's right lower lobe infiltrate, and this becomes pretty textbook right now. And in sickle cell disease, the ACS happens when the sickled red blood cells get stuck in the tiny vessels of the lungs, or sometimes due to infection or fat emboli. Now, the patient even has a prior history of ACS, and the hemoglobin, the sickle cell hemoglobin genotype, both of which raise her risk of developing this condition. Now, the elevated white blood cell count hints an infectious trigger. Now, here the nurse clearly suspects ACS, and the plan includes transfer to the hospital for IV antibiotics and possibly transfusion. So this is the most urgent life-threatening complication on the table right now. Now, why are we not selecting pulmonary embolism? Because with PE, it might seem possible because of the chest pain and low O2 levels, but let's not jump into conclusion, because there is no history of immobility, no recent surgery, no clotting disorders, and the chest x-ray does not show the typical clear fields or wedge shape opacity that you would expect in pulmonary embolism. So this is not a thrombotic issue. This is a classic vaso-occlusion in the lungs. Now, why not we're selecting septic shock? Well, the patient has a fever and a high white count, sure, but their blood pressure is normal and there's no sign of organ dysfunction. And remember that with septic shock, it involves low blood pressure, there's altered perfusion, and there's impending systemic collapse. And that's not what's happening in this case. So the primary issue is still respiratory, not systemic collapse. Now, if you selected priapism, this one's an easy elimination because priapism is a painful, it's prolonged erection caused by vascular congestion, and our patient is female. Get rid of this. So this is only relevant complication if your patient is male with SCD or sickle cell disease. But in this case, it doesn't really apply. Now, we got stroke. Why do you think that this is not applicable? Well, we know that strokes can happen in sickle cell disease and in crisis, especially in patients with this type of genotype. But this patient has no neurological symptoms, no confusion, there's no facial drooping, no weakness, and there are no signs of slurring in their speech. And what we're seeing here is a pulmonary picture, not a cerebrovascular event. That's why we're not selecting that either. Now, let's move on to the assessment findings. We got the options: blood pressure 90/60, altered mental status, right lower lobe infiltrate on X-ray, penile pain and swelling, saturation of 91% on room air, chest pain with cough. One of the answers here is chest pain with cough. And this is classic for ACS. It means that there is ischemia going on, probably to pulmonary infarction, and the productive cough, especially with a fever, it leans forward to infection playing a role. And when you're trying to spot ACS, this combination is one of your biggest clinical clues. It should make your internal alarm go off immediately. Now, what else do we need to select? We are going to select this one, right lower lobe infiltrate on X-ray. This seals the deal because in ACS, the diagnostic criteria include a new infiltrate on the chest X-ray along with respiratory symptoms, and we have both here. And the infiltrate supports the nurse's suspicion, and it reinforces the urgency for hospital care, acute care. So this is what confirms the acute chest syndrome. It not just supports it. Now, why are we not selecting saturation of 91% on room air? We know that the patient is hypoxic, but this is more of a physiologic measurement than a standalone finding. This one supports the diagnosis of acute chest syndrome, but it is not one of the primary signs used to identify, especially that we are leaning towards acute chest syndrome, right? So think of this assessment finding as supportive, not definitive, all right? So this is not specific to ACS. Another thing that you should eliminate is penile pain and swelling, and already mentioned about the priapism, right? Again, this is only applicable for a male patient with SCD. Another is altered mental status. This is something that you would pick if there was a stroke or severe hypoxemia affecting the supply to the brain. You might see confusion or disorientation. But in this case, the patient denies confusion. There is no evidence of neurological changes. And not every fever means meningitis or stroke. So don't let that distract this. Don't let this distract you from selecting this one. Now, if you selected blood pressure 90/60 mmHg, this would indicate possible shock, but in this case, it's not even accurate. The patient's blood pressure is 135/85, so including this would be incorrect based on the data we're given. So always cross-check the vitals that's in the medical record before selecting an answer. Now let's go into the interventions. I hope that you selected those two already. We have options: prepare for lumbar puncture, administer IV fluids at 250 mL per hour, encourage incentive spirometry, initiate heparin therapy, notify provider for urgent hospital transfer, administer supplemental oxygen to maintain saturation of greater than 95%. Now, what are these two actions? One of those is administer supplemental oxygen to maintain saturation greater than 95%. This is your top priority because the patient's saturation is 91%. That's too low, especially in someone at risk for further sickling. And when you give oxygen, this will help reverse hypoxemia. It can improve tissue perfusion and reduce further crisis. And here, our goal is to get the saturation back to above 95%. And this is also within your scope of practice. So start this intervention right away. The other intervention that you should select is notify provider for urgent hospital transfer. It's because the patient needs to be in the hospital right now. The nurse's documentation already notes a suspicion for ACS and recommends a transfer. And this is exactly what needs to happen because at this point, the patient may need IV antibiotics, possible transfusion, and much closer respiratory monitoring. And the nurse's role here is to recognize the urgency and escalate care. Don't forget that this patient came from the urgent care clinic. So there's a need for us to transfer this patient to the acute care setting. Now, when we are looking into the incorrect options here, if you selected initiate heparin therapy, well, we've already said about this that it's not a thrombotic process like a pulmonary embolism, and giving heparin would be unnecessary and can be potentially dangerous instead. There is no order for administering this medication, and there's no indication that this patient has a clot. And this option confuses vaso-occlusion with thrombosis, which is a common but important mistake to avoid. Now, if you selected encourage incentive spirometry, we know that using this device is also helpful in preventing ACS. But once a patient has confirmed ACS, your focus needs to shift to oxygen administration and hospital care. You cannot treat ACS with deep breathing alone, even though this is a helpful tool in recovery, but this is not your first move in an acute crisis. If you selected administer IV fluids at 250 mL per hour, we know that fluids are definitely useful in managing SCD, especially for hydration. But here, we don't have a provider order for fluids, and this rate, 250 mL per hour, is arbitrary. There is no sign of significant dehydration, and we don't want to risk fluid overload in this patient, especially with lung involvement. We know that fluids are supportive, not a top priority here. All right, we're talking about acute chest syndrome. Now, let's move forward to prepare for lumbar puncture. Why is this incorrect? Because there is absolutely no indication for this. The patient does not have confusion, no neck stiffness, or any signs of meningitis or a neurological complication. And lumbar punctures are invasive and should only be done when it's warranted clearly, and definitely not in this pulmonary focused case. So for this test item, always start with the clinical picture. Do not chase laboratory values or isolated numbers. You need to match the symptoms to the complication. Ask yourself if it's a pulmonary in origin, or is it neurologic? Is it genitourinary problem? And when in doubt, always ask, what's the most life-threatening thing that's happening to this patient right now? And you need to know the differences between the diagnostic and therapeutic priorities. And always remember that in a crisis, oxygen, pain control, and escalation of care usually take the lead. So you got to be careful with associating all these answers. Let's move on to our next test item.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's continue with the topic.
It said in the nurse's practice notes, day 2, 8 in the morning, pain reduced to 5 out of 10 with PCA. Saturation 96% on 2 liters O2. Labs, hemoglobin 8.0 grams per deciliter. Hematocrit 23.5%. Reticulocyte count 18%. White blood cells 16,000 cells per cubic millimeter. Total bilirubin 2.8 milligrams per deciliter. Chest X-ray clear. Continue IV fluids. Hydroxyurea antibiotics ceftriaxone. Pay attention to what day and time we are dealing with it right now. We are on day 2, 8 in the morning. Now let's go back into the history and physical. It looks like there are no updates. We have the same info for past medical history, social history, family history, physical exam. So here, our task is to select the 4 most critical nursing actions to address current clinical findings and prevent life-threatening complications in this patient with sickle cell disease. Now, it looks like we have some additional information, or maybe not. We have the same healthcare provider orders, CBC, CMP, chest X-ray, blood cultures, hematology for crisis management. We have the same order for IV normal saline, 125 ounces per hour, morphine, PCA, IV, of course, 1 milligram bolus, 10-minute lockout, ceftriaxone 1 gram IV daily, and oxygen 2 liters per minute, and encourage oral hydration and rest. So, among the nursing action options that you are seeing right now, what do you think would be the 4 most critical nursing interventions? Well, one of those is before we go do that, the lab values are the following, but it looks like we already scanned these labs as well. We got hemoglobin, hematocrit, reticulocyte count, white blood cells. So this is on day 2, since we're focusing on day 2 right now, and total bilirubin of 2.8. And on day 2, there's no infiltrates found yet in the chest X-ray. Now, what do you think would be one of the answers here? One of those is assess respiratory status and lung sounds every 4 hours, because we know this patient has a history of acute chest syndrome, which is one of the most dangerous complications of sickle cell disease. Even though her oxygen saturation looks decent at 96% on 2 liters and her X-ray is currently clear, that doesn't mean she is in the clear. She's still on oxygen, her white cell count is high, and her respiratory rate has elevated earlier. All right, so this one tells us her lungs are still vulnerable. So we got to do frequent respiratory assessments so we can help catch those early signs of acute chest syndrome like crackles or worsening oxygen levels before this worsens. Another nursing action that you should select is monitor for neurological changes every 4 hours, because this patient is at risk for stroke. Because of that hemoglobin, sickle cell hemoglobin genotype, which puts her at greater risk for cerebral vaso-occlusion, and she's currently anemic. Her hemoglobin is 8.0, which increases blood viscosity. Now, If she were to develop sudden confusion, maybe weakness, or any other neuro change, would need to act fast. So regular neuro checks are a must to catch a stroke early and possibly prevent long-term damage. Another nursing action that you should do is administer ceftriaxone IV as ordered, because infection is one of the most common triggers for a sickle cell crisis. And this patient is likely fighting off something. And her white count is high, her bilirubin is elevated, and she had a fever earlier. And take note that sickle cell disease patients are functionally asplenic. It means they don't fight off certain bacterial infections well. So giving IV antibiotics like ceftriaxone helps prevent sepsis or pneumonia, which can be fatal in this patient. Now, another thing that you should select is encourage incentive spirometry every 2 hours. Again, we are on day 2, right? You really want to keep her lungs open and moving, especially since she's been in pain and breathing shallowly. And the use of incentive spirometry is going to prevent atelectasis and other pulmonary complication, especially if she has a history of ACS. And this one also complements your ongoing respiratory assessment. It will help ward off those complications like infection or pulmonary infarction. So you're being proactive, not just being reactive. And so the rest of the options are incorrect. So if you selected titrate morphine PCA based on pain assessments, well, I want you to go back in the first section of this test item. Pain control is definitely important, but she's already on PCA. And here's the thing. Her pain is under better control now. It's down from a 9 out of 10 to a 5 out of 10. So yes, we'll continue monitoring, but the immediate priority is not tweaking or adjusting her PCA settings. And we just don't do that without an order from the physician. Instead, we need to keep our eyes on what might actually kill her first, and that is stroke, that's the acute chest syndrome, or the infection. Now, if you selected or request a transfusion order for hemoglobin less than 7 grams per deciliter, now remember that her hemoglobin is currently at 8. So she doesn't meet the usual transfusion threshold for an uncomplicated crisis. Now, unless there's a complication like stroke or acute chest syndrome, we don't automatically transfuse. So giving blood unnecessarily could lead to other complications, could cause iron overload, or alloimmunization, which we want to avoid here. Now, if you selected apply cold packs to painful joints, this is dangerous misconception, because cold therapy might sound comforting for joint pain, but in sickle cell disease, cold can cause vasoconstriction, which makes things worse. It will make the sickling worse, especially into the joints. And this is contraindicated because this patient's pain is already being treated appropriately with opioids, not with cold packs. Now, if you selected monitor for signs of renal impairment, so we're talking about urine output and creatinine, we know it's true that sickle cell disease can affect the kidneys in the long term, but there is nothing in the case right now to suggest that there is acute kidney problems. There is no change in urine output, no abnormal creatinine, no history of nephropathy, and while it's a valid long-term concern, in this situation, it's just not the priority. If you selected teach stress management techniques to reduce pain triggers, this is also incorrect, even though we know that stress can trigger crisis, but this patient is not currently showing signs of stress, and teaching coping strategies is more of a long-term intervention. It's not something that prevents acute complications like infection or stroke or acute chest syndrome. And that makes this action supportive, but non-urgent for right now. If you selected obtain a repeat chest x-ray to rule out delayed infiltrates, well, this kind of sounds logical in the surface. But her current chest x-ray is clear. We're talking about day 2. And there are no new symptoms like worsening dyspnea or a drop in their oxygen saturation. And so without new changes, there's no clinical reason to repeat the chest x-ray right now. Instead, we are going to focus on assessing and make sure that we are having the patient use the spirometry regularly to watch for changes before jumping into another x-ray. And so here, I want you to prioritize the complication prevention over symptom management. Pain is important, but complications like the acute chest syndrome or stroke are life-threatening. So you need to be alert for those hidden red flags, especially in conditions with a history of high-risk complications, such as this patient with ACS history. And don't forget to choose those interventions that are timely, nurse-initiated, and evidence-based, like the administration of O2, the administration of antibiotics as prescribed, and regular assessment. So here, eliminate those nursing actions that sound helpful but don't fit the immediate situation, like non-urgent teaching or unnecessary imaging. So keep that in mind. Here we're going to shift into our next test item.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
Number 4. So let's just scan through the same information and this patient's history and physical. I'm not going to read this again. So feel free to pause the video and just scan through each of these information. It said on day 10 at the bottom, at 9 in the morning in the hematology clinic, pain resolved, no dyspnea, saturation 98% on room air, hemoglobin 8.5 grams per deciliter, reticulocyte count 15%, reports of hydroxyurea fatigue, discussed adherence, referred to a social worker, blood pressure 128, over 80, heart rate 88. So I'm just giving you the idea here. I want you to go back into the history and physical, but take note that we are now on day 10. Okay? Now here's your task. It said here, on day 10, the nurse at the hematology clinic is assessing the patient's response to the treatment. Indicate whether each intervention is essential, supportive, or non-essential for optimizing long-term sickle cell disease management. Here we go. We got the following interventions. What do you think about reinforced hydroxyurea adherence? Obviously, this is essential, because this medication is one of the most powerful drugs that we have for this patient for managing their sickle cell disease. This medication works by boosting fetal hemoglobin, which is going to help prevent those misshapen cells from clogging the microcirculation. and the patient is prescribed hydroxyurea but reports fatigue from it. So you have a possible adherence issue on this patient. Hydroxyurea fatigue, that's quite significant. And that's why reinforcing the adherence to this medication is very critical to preventing future crises, to prevent hospitalizations, even life-threatening complications like stroke or acute chest syndrome, because we know that skipping this drug will put this patient at real risk. Now, why are we not selecting supportive for this intervention? Because this one is not extra. It's the front line of their therapy. So if we're calling this supportive, it's minimizing its importance in their disease control. If you selected non-essential, well, this patient has a severe sickle cell disease history. And if you're ignoring hydroxyurea, it's like ignoring insulin in diabetes. So totally inappropriate. Now let's move on to intervention. Refer to a social worker for fatigue coping. The answer here is supportive. Well, let's talk about fatigue coping. This is a real issue in sickle cell patients because this is linked to their anemia, the medications that they're taking, and just living with this chronic illness is already a bit much. While this is not really life-threatening, it definitely affects the patient's daily functioning, their work performance, and possibly medication adherence. Now, a social worker can help the patient with coping strategies, community resources, and maybe even work accommodation. So that makes this a valuable intervention for this patient's quality of life, but it's not a treatment that changes the disease process directly. So we are putting this as a supportive measure. And of course, this is not essential because it doesn't treat the disease. And this is also non-essential because ignoring this one also overlooks something that could undermine the success of your essential treatments. Now, moving into the third intervention, monitor for stroke symptoms. What do you think of this one? This is, of course, essential because stroke is one of the most devastating complications of sickle cell disease, especially in patients with the sickle hemoglobin genotype, and they have frequent crises. Even if there are no symptoms happening today for this patient is at high risk due to the anemia and a history of vaso-occlusive events. And when you're monitoring this patient for early signs like slurring of speech, confusion, or weakness can literally save her life and also to prevent permanent damage. And in the long-term care, this kind of surveillance is non-negotiable. So keep this in mind. It's not supportive because stroke prevention is the core goal of long-term management in SCD. It's not non-essential because ignoring stroke risk in this patient would be dangerous and could completely be off base. Number 4, teach smoking cessation techniques. What do you think about this one? We are going to put that as non-essential. Now, the context for this really matters because our patient does not smoke. We know that smoking can definitely make sickle cell worse. It can reduce oxygen delivery to the body tissues. But then again, our patient is non-smoker. Look into the history and physical. So this is irrelevant. So when you're teaching them to quit something they're not doing is just unnecessary. So your time is better spent on interventions that match the actual risks. So ignore this one. And this one is not essential either because there's no behavior here to change. And it's not even supportive because it doesn't support or reinforce any current treatment or need for this specific patient. Now let's move on to schedule monthly complete blood count checks. This is essential. This is very huge because Regular complete blood cell count are how we are going to monitor the patient's anemia, their white blood cells, and the potential toxicity from hydroxyurea. And the laboratory can help guide where we should change the dose or even stop the treatment or watch for complications like infection or aplastic crisis. Now, for this patient whose hemoglobin is 8.5 and who's actively taking hydroxyurea, these labs are part of safe evidence-based care. This one is not supportive because lab monitoring is central. It's not secondary, and also not non-essential because missing this would mean flying blind on how the patient is responding to the treatment. All right, let's jump into the next intervention. It said, educate on hydration importance. This is categorized as supportive because hydration is well known to reduce blood viscosity and prevent sickling, especially in hot weather, if they are sick or if there is physical exertion. Even though it's not a direct treatment like hydroxyurea or transfusions, this one helps prevent triggers or for crisis. So this one is a great tool for self-management and deserves to be part of your patient's teaching. And since it doesn't really alter the disease itself, it's classified as supportive, not essential. Okay? This one is not non-essential because ignoring this one could let simple things like dehydration, it could push the patient into another painful crisis. Lastly, we have assess for depression symptoms. What do you think about this one? This is supportive. Okay, let's not forget the mental health side of the chronic illness. Well, with the sickle cell patients, they deal with chronic pain, the hospital stays, life disruptions, so the risk for depression is real, even if there are no obvious symptoms right now. And so checking their mood and their mental health can help us catch those problems early and connect the patient with the resources that they're going to need. So this kind of screening will support medication adherence, their pain coping, and overall functioning as well. And this one is not essential because depression does not directly affect sickling or blood counts. This is also not non-essential because we know that mental health matters. And ignoring this one could undermine treatment success. So when you're answering a question like this one, always match the intervention to its impact and always ask yourself if it directly modifies the disease, so that's going to be essential, or if it improves quality of life or support adherence, so that's going to be supportive, or if it's relevant to the current case, that's not essential, or irrelevant, I should say. I hope that you were able to capture all these correct answers in this test item. Let's move on to our next item, number 5.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
It said here on day 14, the nurse at the urgent care center is assessing the patient for new complaints. Highlight the findings that directly support the need for urgent nursing actions to address acute chest syndrome. Here we have the nurse's progress notes, and it said day 14 at 1 p.m. urgent care, new chest pain, cough, saturation 91%, blood pressure 135/85, heart rate 108, temperature 101.2 degrees Fahrenheit, chest x-ray shows right lower lobe infiltrate, suspect acute chest syndrome, transferred to hospital for IV antibiotics, possible transfusion. Here we have the lab results for day 14, hemoglobin of 8.2, white blood cells of 17,500 cells per cubic millimeter, and chest x-ray on day 14 now showing a right lower lobe infiltrate. Now, what are those findings you think can directly support the need for urgent nursing action? Anything that is pointing toward acute chest syndrome. So I want you to carefully select the phrases and words in this item. Now, one of the answers that you should highlight is the new chest pain. This is very critical because in sickle cell disease, the chest pain signals pulmonary vaso-occlusion. Again, a hallmark of ACS. So this is not the same as the patient's typical pain from a vaso-occlusive crisis, which usually affects the joints or the back. We're talking about chest here. The chest pain in this setting suggests the lungs are directly involved, and the nurse should immediately assess the patient's breathing, their oxygen status, and notify the provider, and to prepare for escalation to higher care. Another is to select the cough. This is also critical because a new cough means that the lungs are irritated or involved from either an infection or could be inflammation due to the sickled cells. So it could signal pneumonia or consolidation. And this is going to really matter, especially in someone with sickle cell disease and a new chest pain, because this is a sign of ACS. It shows the lungs are struggling and it supports the need for hospitalization. You're going to highlight this one as well, saturation of 91%. This is hypoxemia. Normally it should be greater than or equal to 95%. Now, a sudden drop from 98% on day 10 to 91%, we are talking about day 14. This indicates new oxygenation problems, possibly from blocked lung blood vessels or even worsening infection. And we know that hypoxemia is very dangerous in SCD. It worsens sickling. It can lead to a cycle of respiratory decline. So this one calls for supplemental oxygen and urgent escalation as well. Another thing that you should highlight is the temperature 101.2 degrees Fahrenheit. This is critical because fever in someone with sickle cell disease may signal infection, which is also a common trigger of ACS. And even a mild fever can mean a sepsis or pneumonia is developing. So you got to start or continue antibiotics here. Also monitor for signs of worsening respiratory status or sepsis. Another thing that you should highlight is chest x-ray shows right lower lobe infiltrate, right? So this is also the definitive diagnostic feature of ACS. It proves the lungs have a new consolidation due to the infection or infarction. And the changes that we are seeing here is basically giving us a picture of an urgent hospitalization. So we need to initiate IV antibiotics here, possibly consider transfusion as ordered, and possible ICU level of care. Now let's move into the laboratory results. Of course, we have the white blood cell count of 17,500. This is elevated. It supports infection or inflammation, which can trigger the ACS. And when you're going to pair the leukocytosis with the fever and the cough, this also reinforces the urgency of antibiotic administration and hospital transfer. Now, another thing that we should not forget, even though it's already highlighted in the nurse's progress notes. We're just going to highlight this one as well because this is very significant. Right lower lobe infiltrate shown in the chest x-ray on day 14. Right? All right. The other phrases and words are incorrect. So if you selected blood pressure of 135/85, this is not highlighted because this is a non-specific finding. And the blood pressure can increase from pain or maybe anxiety, and it does not confirm ACS. So this is not low enough to suggest a problem, maybe a shock or hypertension. It doesn't guide urgent action here. And the heart rate of 108, it's tachycardic, but that's not, this is something that you will expect when the patient is in pain, they have fever, or maybe they have anxiety. And tachycardia alone is too non-specific, and it doesn't confirm acute chest syndrome as well. Now, if you selected hemoglobin of 8.2, well, we know that this is low, but it's not new, or it's not significantly worse than the previous days. When you go back into the previous lab results that we have seen, this one is not specific to the acute chest syndrome. And when we deal this hemoglobin alone, it does not guide urgent action unless it's markedly low, such as lower than 7 grams per deciliter, or if there are any other signs of perfusion problems. And that's why we are not highlighting hemoglobin this time. Alrighty, let's move into our last item.
Before moving ahead, here's something you need to hear if you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month. Then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
It said, following the day 14 urgent care visit for chest pain, productive cough, fever of 101.2 degrees Fahrenheit, and a right lower lobe infiltrate, the patient was hospitalized for IV antibiotics, ceftriaxone, and oxygen therapy. She was discharged on day 18 with resolved respiratory symptoms, with saturation of 98% on room air. She continues hydroxyurea 500 milligrams daily and folic acid 1 milligram daily. The nurse is developing a long-term care plan to prevent future crises, manage chronic symptoms, and monitor disease progression, considering her history of vaso-occlusive crisis and recent hospitalization. Now, what are we doing here? So you're supposed to categorize each nursing action into the most appropriate group based on its primary purpose for optimizing long-term sickle cell disease management post-hospitalization, or preventing recurrent crisis, managing chronic symptoms, or monitoring disease progression. Select all actions that apply to each group. So let's take a look into this matrix. We got categories of preventing recurrent crisis, managing chronic symptoms, and monitoring disease progression. So what do you think would be the correct nursing actions for the first category? So in this category, you're going to focus on preventing the sickle cell crisis, such as the painful vaso-occlusive episodes or the acute chest syndrome, to keep the patient stable and out of the hospital. So what do you think are the correct options here? Well, one of those is reinforce hydroxyurea adherence daily. This is very critical, especially for this SCD patient This can increase their fetal hemoglobin, which reduces sickling. It also prevents the crisis. And remember that she has multiple crises in the past and an acute chest syndrome as well at age 25, plus the recent ACS on day 14. So with chest pain and lung infiltrate, these show why sticking to this medication is non-negotiable. I said non-negotiable. They need to adhere taking in this medication. All right. Now also remember that she reported fatigue on day 10 and day 21, which might lead to missed doses. So here, your role is to reinforce compliance to taking this medication daily through education or tools like pill organizers, so she can be reminded to take the drug to prevent another crisis. Now, another action that you should select is educate on avoiding extreme temperatures, because extreme heat or cold can thicken the blood. It can trigger sickling and crisis in this patient. And this patient was dehydrated on day 1, and her recent ACS suggests she's sensitive to triggers. And now educating her to avoid prolonged heat or cold, like staying out of the saunas or dressing warmly, is something that you'll do as a nurse. Remember that she's a graphic designer with a partner, so she can likely apply these tips at home. And this education also prevents crisis by controlling environmental risk, especially post-hospitalization. Another intervention that you should check here is administer pneumococcal vaccine per schedule, because this patient's hemoglobin sickle cell genotype, it means that her spleen does not work properly. So this is going to leave her really prone to serious infections like pneumococcus, which can trigger ACS or sepsis. Now, her day 14 event, when she had the ACS, it came in with the fever. Her white blood cell count was 17,500, so those hinted an infection. And this will ensure that she gets pneumococcal vaccination, like say the PCV13. And this is your job as a nurse as well, to promote this intervention. It will prevent infections that could spark another crisis. This is a huge thing. Now, another intervention that you should check off here is encourage consistent oral hydration. That's 2 to 3 liters per day, because when they stay hydrated, this is very huge for SCD patient. It keeps their blood from getting too viscous, which will prevent the sickling and the crisis. And again, this patient was dehydrated on day 1, and her recent ACS shows why her hydration really matters. So your role again is to encourage the patient to drink at least 2 to 3 liters of water daily, and that's about 8 to 12 cups to replace the IV fluid so that she got in the hospital. Now, let's look into the incorrect answer, which is encourage smoking cessation education. I think we have already talked about this. This one is important for those smokers, but since our patient is a non-smoker, so this is irrelevant in this case. Let's go into the next category, managing chronic symptoms. So in this category, we're going to help the patient manage the ongoing challenges of sickle cell disease. So things like fatigue or stress that affect her daily life. So this is about quality of life, not just preventing the crisis. So one of the interventions that you should check here is to teach stress reduction techniques, because sickle cell disease is very tough. And of course, with the recurrent crisis, hospitalizations, this will pile up into a stress for this patient. And her fatigue on day 10 and day 21 make it even harder to deal with, especially as a graphic designer balancing work in her home. And teaching her stress reduction like mindfulness or breathing exercises can help her manage that mental load. And as a nurse, your responsibility is to give her those techniques to cope, to improve her daily life, which is what this category is all about. Another thing that you should select is monitor for signs of depression, because the constant grind of sickle cell disease crisis, the recent ACS, the fatigue can put this patient at risk for depression. This could affect her job or her hydroxyurea adherence. And your role as a nurse here, you need to check for signs like low mood or lack of interest, maybe with a quick screening tool. So catching depression early means you can connect her to counseling, could be supporting her mental health long term, which is key in this category. Another thing that you should check here is to assess fatigue impact on daily activities, because fatigue is a big issue for this patient. Her hemoglobin level is low at 8.4 grams per deciliter. And also the hydroxyurea might add to that one as well. And remember that she mentioned it on day 10 and day 21. And as a graphic designer, it's likely affecting her home and her work life. So as nurses, you're going to ask how the fatigue's hitting her. Like, is she struggling with the deadlines as a graphic artist? So that will help you suggest strategies like pacing herself or even to manage the tasks on the daily basis. So this is about improving her life with SCD, right in line with this category. Now, if you selected refer to a social worker for resource support, this is incorrect. We know that social workers can help with things like insurance or transportation. And this patient had a referral on day 10. But on day 21, there's no sign of new issues. She's stable, living with a partner, she's working. Her fatigue is handled by assessing its impact, so a social worker referral is not needed now. And as nurses, your focus is on stress and depression instead. So this option tests if you're using the electronic medical record or the information that I have showed you earlier in order for you to avoid those unnecessary steps. Another incorrect option is teach recognition of early crisis symptoms. We know that teaching this patient to spot early crisis signs like new pain or fever can help her act fast to avoid another ACS. But that's about preventing crisis. We are talking about monitoring or actually managing chronic symptoms. So this one does not, or this is something that's not really driving. So this one belongs to crisis prevention, not here. Now let's jump into the next category, monitoring disease progression. So this is all about monitoring how the SCDs affects the patient's life over time and catching complications early to guide her care. Now, one of the interventions that you should select here is coordinate annual transcranial Doppler screening, because with sickle cell disease, this patient is at risk for stroke because the sickle cells can block the brain arteries, and her recent ACS signals severe disease, so making stroke prevention very critical. And you have to coordinate this patient with their annual transcranial Doppler to check the blood flow in her brain to spot any risk of stroke. So if it is off, then she might need transfusion. So as nurses, you'll set this up to monitor her SCD's progression. And this is also a key step post ACS to keep her safe long term. Now, if you selected schedule monthly CBC checks, also important, because this can give us a better picture how she's managing her sickle cell disease. And she's also taking the hydroxyurea, so this can keep track of how the anemia can worsen or not. And of course, she's taking the hydroxyurea. There's effects on that one, so catching issues like a sudden blood count drop or low white blood cells can be easily detected for this one. Now let's move on into the next intervention. One of these is to monitor hemoglobin trends weekly, because right after the acute chest syndrome, we need to watch her hemoglobin closely. We're going to have to do weekly checks to see if the hemoglobin is stable or if it's dropping. And any drop could mean a hemolytic crisis. Take note of that. Or if it might show how hydroxyurea is working. So this is specifically important now that the patient was just discharged, and this is to confirm that she is recovering. And your role as a nurse, you need to monitor these trends to monitor her SCD progression in the short term. So you have to catch those problems early. Another thing that you have to check here is to monitor renal function every 6 months, because SCD can damage the kidneys over time due to the hemolysis and low oxygen. Even though the patient has no kidney issues right now, checking their renal functions like creatinine every 6 months is standard to catch early kidney damage. And after her ACS, this monitoring can ensure that her kidneys stay healthy as her disease progresses. So your role as a nurse is to make sure that you're coordinating these tests to track her long-term impact of the sickle cell disease. So stay proactive. Now, if you selected assess liver function test every 6 months, isn't correct in this context, but you might consider liver test because of a hydroxyurea or high bilirubin from the hemolysis. But in the case scenario, there is no liver disease history, no symptoms like jaundice, and that's why it's incorrect. And the bilirubin is also normal. There's no liver problem in the reports, and her hydroxyurea dose rarely causes issues. And the kidneys are a bigger sickle cell disease concern, so we prioritize those tests instead. And if you're obtaining orders for LFT checks, now would be unnecessary, and this option is only placed to test if you're focusing on the right risks. So that's it. Here's the recap in what we've learned today. When a patient is having a sickle cell crisis, it's very important to act quickly and focus on preventing complications like acute chest syndrome. So you need to start by recognizing the signs early. So you have to watch for things like severe pain, low oxygen levels, fever, leukocytosis, because these could mean a vaso-occlusive crisis or even something more serious like the ACS. After that, begin the key treatments right away as prescribed. So we're talking about the pain medications like IV morphine to manage their severe pain, also administering the prescribed IV fluids to help reduce the sickling, and administer oxygenation if their oxygen saturation drops. So these will help improve their blood flow, keep the tissues from being damaged. And you got to make sure that you are monitoring the patient very closely, checking their lung sounds, their neurostatus, often to catch signs of the acute chest syndrome or maybe stroke early, and make sure that you encourage the use of incentive spirometry to prevent lung problems, especially if the patient is not having any severe issues in their breathing. Now, if there's a chance of infection, you have to administer those prescribed antibiotics to make sure that we're fighting off any ongoing infection. And for long-term prevention, you have to teach the patients to drink plenty of fluids, let's say 2 to 3 liters per day, and encourage them to take the medication hydroxyurea regularly to reduce how often crisis can happen. And don't forget about monitoring their complete blood count, their hemoglobin levels to manage the anemia. For short, we have to focus on the airway, the breathing, and the circulation. So don't forget about dehydration, the oxygenation, and make sure that you are allowing this patient to rest to prevent more stresses. You have to manage their pain quickly as well. You got to make sure that you're checking the electronic medical record in the scenario for lab values and the vitals, and always think ahead to prevent future problems. So that's it. I want you to keep practicing those case studies and let us know how your prep's going. Now, if you find this episode helpful, don't forget to subscribe to the channel and give this video a thumbs up and share it with your friends who are also reviewing for the NCLEX. Thank you for watching. I'll see you in the next review session.